And the next speaker, Werner Butz, who's going to update us on the RESPECT and its effect on PFO closure practice.
Good morning, ladies and gentlemen, dear Chairman. First of all, I would like to thank the organizers for the kind invitation to be here. This is my slide of disclosures. And I would focus my presentation first on a brief summary of the RESPECT trial, the results of the RESPECT trial, which was presented a few months ago, also here in Miami. I will give you some personal comments, look at the future of PFO closure for cryptogenic stroke, and finally come up with some conclusions. So, as you probably know, the RESPECT trial is a multi-center trial in a one-to-one randomization stratified by site and by the presence of an atrial septal aneurysm. Stratification in two groups, the device group, where a PFO is closed with the Amplatzer PFO occluder, and in a medical treated group, where 5 medical treatment regimens were used: aspirin, warfarin, clopidogrel, and a combination with aspirin. It was an event-driven trial, so the enrollment was continued up till the 25th endpoint was reached. Inclusion criteria, important. Patients were aged between 18 and 60 years, had to have a PFO, had to suffer from a cryptogenic stroke within, and I think this is also important, a time period of 270 days. And it's important to know that it is a cryptogenic stroke that was included in the study and not a TIA, as it happened with, for example, the Closure 1 trial. Exclusion criteria mainly focused on systemic conditions that suggest other mechanisms for stroke, for example, atrial fibrillation. So the primary endpoint was a recurrence or combined endpoint, recurrence of a non-fatal ischemic stroke or fatal ischemic stroke or early post-randomization death defined as all-cause mortality. So patients were enrolled, up to 980 patients. Then the randomization was done, 499 in the device group and 481 in the medical group. In the device group, there was an attempt for closure in 464 patients, and in the medical treated group, patients were treated with almost half of them with aspirin, 1/4 with warfarin, 14% with clopidogrel, and about 14% also with a combination with aspirin. So the mean age of this patient group was about 46 years, and the days from qualifying stroke to the randomization, the days were 130, with a standard deviation of 70 days. There was an equal distribution of the presence of an atrial septal aneurysm in both groups. About 1/3 suffered from an atrial septal aneurysm, and there was also an equal distribution of stroke size. So I jump to the endpoints and the primary analysis. 9 events occurred in the device group and 16 events occurred in the medical treated group, and all these patients had stroke as an event. This was calculated to a risk reduction of 47%, but unfortunately the p-value was 0.16. But there was a problem in this primary analysis based on the row count cohort, because there were 48 dropouts in the device group and 90 dropouts in the medical treated group. So that there was a significant difference in total exposure time between the device group, which was larger, when compared to the medical treated group. P-value 0.009. So the investigators had to do some other statistics, which was the typical Kaplan-Meier survival curve, where the dropped out patients were censored. And as you can see now, there is a risk reduction of 51%. Again, 9 events in the device group, 16 events in the medical treated group. But again, unfortunately, the p-value reaches 0.08, which is not statistically significant. But then another problem occurred in this analysis. 3 of the 9 events occurred already before the device implantation. So that's a problem. This is 33% for the device group. So secondary analyses were done, and when patients strictly adhere to the study protocol, in this per protocol analysis, there was a risk reduction of 63%. 6 events in the device group, 14 in the medical group, and this time there is a positive result with a log rank testing of 0.03. And this is, I think, a very important message for the future. If you just compare patients treated with medication and patients treated with a device, then the risk reduction is even going up to 73% with a log rank value of 0.007. So highly statistically significant. So what really does RESPECT learn us? Well, the first thing is that the policy of closing a PFO after a mean time, and I think this is important, of 130 days after the qualifying event is not superior to medical treatment. But it also learns us that medical treatment failed during the bridging period between the qualifying event and the closure. But it also showed us that PFO closure itself is superior to medical treatment, but you have to adhere strictly to the protocol. So this is very important information. I haven't shown you these results concerning safety, feasibility and effectiveness, but we know now that device closure can be safely done. Complication rates between 0 and 1.6%, and this is completely different when you compare this with the Closure 1 trial, where you had complications up to 10%. Device closure is feasible. Device closure might be effective with a closing rate, effective closure of 94%. These results are very good. So what can we optimize, or what do we have to look at in the future? How do we have to deal with the bridging period? Do we have to close faster after the event? Or do we have to use more aggressive anticoagulants? And we have to think, were these events unavoidable because the PFO was not pathogenic enough? You have to realize it was allowed to include patients up to the age of 60, and several of the patients had a quite high cardiovascular risk profile, suffering from diabetes, systemic hypertension, being smoker, and having hypercholesterolemia. So if you look to the European score, some of these patients were here having a high cardiovascular risk profile, and probably the patients that will benefit, who will benefit from PFO closure, has to be in this range, the green zone, of having a very low cardiovascular risk profile. So we have to admit there is growing evidence of benefit of closing PFOs in patients with cryptogenic stroke. In the beginning, in the years of 2000, there were only retrospective and prospective trials without a control group, mainly focusing on feasibility, efficiency, and safety, but they focused really on the device, not really on the patient selection. In the next step, some prospective non-randomized trials with a non-matched control group occurred, showing benefit of PFO closure. You can go even further in the evidence, and a very nice paper of Bernie Meyer was published in Circulation last year, where there was a prospective non-randomized trial, but with a propensity score matched control group, where you clearly see that even if you evaluate just 100 patients in each group, you might have a substantial benefit of PFO closure versus medical treatment. Unfortunately, there are 2 trials that do not show a benefit. The Closure 1 trial, but everybody knows the methodological issues of the Closure 1 trial. And also the PC trial did not show a benefit of PFO closure versus medical treatment. But in my opinion, these trials are underpowered. If RESPECT shows that you need at least 400 to 450 patients in each group to show statistical differences, these trials are then clearly underpowered. And today we have the RESPECT trial reaching almost the 100% level of evidence that PFO closure is beneficial in patients with suffering from cryptogenic stroke. So in conclusion, ladies and gentlemen, Mr. Chairman, RESPECT shows that the policy of PFO closure tends to be superior to medical treatment, but we need to revise the bridging period. It shows that PFO closure itself is superior to medical treatment when strictly adhered to the protocol. And RESPECT reopens the door for PFO closure in carefully selected patients, patients with 1 cryptogenic stroke, and second, patients with a typical pathogenic PFO, which is a very low cardiovascular risk profile. And I discussed this recently with our neurologist. Maybe we have to look for a longer follow-up period because the mean follow-up time was just 2.6 years. And if you look to the Kaplan-Meier survival curves, these curves seem to diverge more and more in time. So maybe we have to wait a few years to show these statistical differences also in the intention to treat analysis. Thank you very much.
We are going to leave questions to the end when we have time. Hopefully there'll be some time for discussion at that point. The next presentation is the update on the ADO2 and inductor closure and premature evidence for Joachim.
Thank you, everybody. Thank you, the organizer committee. This is always a great meeting. I'm happy to share my experience. I'm also mostly happy to see the experience of the others. It's a great meeting for discussion, and I hope it's going to continue forever. I've got the usual conflict of interest. I'm a proctor for AGA St. Jude. I'm starting saying that all the previous devices that we're using give optimal results for ampular PDAs, what we call type A PDAs. This is the typical anatomy in kids once they're grown, in mature humans. But all those devices were also designed for bigger kids, and of course, most of them are incompatible with access in prematures, except of course coils. The premature, however, is very different. Is a PDA is almost always of a tubular variety, what we would call a type C, and we would say it's a fetal pattern. It's exactly the same kind of ductus we would see in fetal echo. It's a tubular long ductus. The tubular shape means that there's no significant aortic ampulla or pulmonary narrowing, which means that we're not going to take into account any narrowing at the pulmonary end, but we need to take into account the tubular diameter for the choice of our device. And again, it retains its fetal characteristics, means it's a tubular structure, and it's usually pretty comparable in size to 3 to 6 millimeters, which is to the aorta, which means about 3 to 6 millimeters. And again, it looks like a fetus. And it's a rather long structure, and most of all, it's a reactive structure. So any angio you do doesn't exactly reflect what this ductus is going to look in 5 minutes. So it's more a fistula than an ampular ductus. And of course, this means we cannot use any device designed with retention discs. So we need to have new devices or use other devices and other techniques. And these devices need to have no or small retention discs. The device needs to be completely deployed inside this long fistula or tubular ductus to avoid protrusion on either side. And I feel, and most people feel now, that plug-type devices are going to be better than coils because they have predictable radial force and final shape. And we don't need multiple coils because usually always a single plug will do the job, and they can be recaptured and repositioned. So these are all the devices which became available, sequentially, and we have experience with all four, but of course I'm going to speak more about the last one. We offered closure in prematures since December 2009 with the ADO2. We wanted initially, and we still select patients to be, now it's more than 1 kilo, I would say, but initially 1.5 kilos. We want older patients because we wanted ductuses less reactives to start our experience. We wanted patients, of course, who had failed the usual treatment. And most importantly, we concentrated on patients who are bad candidates for surgery because surgery does a real good job. And of course, we wanted to do that on patients who were contraindications to surgery, either because severe bronchodysplasia, it's almost all of those cases, or because of previous thorax surgery. So we started with the ADO2 very briefly. This, we did it only in one patient, and you see that the ADO2 is not adequate because you need to squeeze it too much, and the retention discs then become longer, and then it protrudes either side. We did some cases with the plug 2, which is clearly superior, but still you have to squeeze it, it elongates, and of course there's a limit to this, and eventually in smaller kids, this ductus is just perfect, but any smaller kid, it wouldn't be okay. We went then for the plug 4, which needs less compression, but it's still a very long device. So again, very good results, but we felt that for smaller kids, it wouldn't work. And then the ADO2 became available in Canada in 2011, and we started using it since then, and it's the only one we're using now. We bring the kids to the cath lab, general anesthesia. Initially, we would puncture the artery to get angios post-release to assess the position, but now we don't do it, so we need only to stick a 4 French in the femoral vein. We do no hemodynamic study. We get very quickly the usual angios. The ADO2AS is actually an hybrid between an ADO2 and a plug-2. So it's like a kind of a plug-2 with just very small retention discs, which are just a little bit bigger than the central lobe. The central lobe itself can be very short, down to 2 millimeters, and of course everything can be released in 038 catheter, 4 French. These are the sizes available, 3, 4, 5, and for each one, small, middle, and long central lobes, and the disc is just 30% larger than the central lobe. It's been approved in Canada. We used it as a special access for 18 months, and now it's been approved since the November 2012, which brings us back to the very interesting debate yesterday about availability of devices in the US. We've got 3 options to choose the size. We could say 150% of the tubular diameter for the retention disc. More practically, we take a central lobe which is slightly bigger than the tubular diameter, and we don't take into account any pulmonary narrowing, because we know it's a labile thing. And we can also take a surrogate measurement, which is the descending aorta, which usually matches very well the tubular diameter, and then we get rid of the problem of PDAs who would be reactive. And it's very, very easy to measure. So we cross anterograde. We don't have any arterial access anymore. Very easy to cross. And you see very well that it's a very long ductus, but most of all, you can see that the images are almost nicer by echo. You can see here the end of Dr. Marie-Josée Rabouisson doing the job. We measure things, length, diameter of the ductus, of the tubular ductus, and diameter of the aorta, and you don't see the numbers, but they're exactly or more or less the same by echo, which means it's a very, we don't need eventually angio anymore. In this case, the ductus was 4.7, aorta was 4.1, so we choose a 5 millimeter ADA2AS, and since it was a very long ductus, 17 millimeters, we could go to the mid-length, the 4 millimeter length of a central lobe. This is a fellow deploying the device, just to tell you it's very easy to do, and immediately Dr. Rabouisson tells us that the device is too much into the aorta. So my fellow recaptures. Again, it's very easy. Brings it back a couple of millimeters, deploys it, and then Marie-Josée can tell us that this time the ductus, the disc is just flush with the aorta with no acceleration. We still measure the, we advocate measuring the discs now to be sure there's some compression. The nominal diameter of this disc should be 6.5, and now it's 5.6, which means the disc is compressed, which means it should be a stable device. We still do, for now, an angio on the pulmonary side. We have no aortic catheter, of course, which shows there's a small length. Note that now the ductus is spasmed, is a little smaller because it's a reactive duct. And you see very well, again, a very good correlation with a good distance between the device and the pulmonary artery. You can see here a little thrombus, which is formed in the, attached to the guide wire. We see it sometimes, and when we remove it, either goes to the pulmonary arteries or it's recaptured in the catheter. Then we release the device, usual way, and we do a last checkup. The thrombus is gone. You still have a little distance. You see now that the pulmonary artery is bigger again, so you can see very well it's a very labile structure. And you can see on the aortic side, it's still flush with the aortic side. We tend to put the device as close as possible to the aortic side, so less chances to push it with the arterial pressure in the pulmonary circulation. So these are our results, 15 patients. I grouped them between the old devices and the new ADO2AS device. You see they're very young prematures, 28, 26. We do it late, it's a choice, so it's about 1.5 months after. The weight is 2.4 for the average weight, for the initial series. Now it's down to 1.9, and the lowest one is 1.3, and I do feel very comfortable now if we have younger patients, but of course our neonatologists are still a little scared. Occlusion rate very quickly, 100% in both. We had, as I told you, problem with protrusion of device on the aortic side in the first series. It tends to disappear with time, but still, you see now we don't even have it initially. No other device-related complication, and procedural time and fluoroscopy time, although they're done with fellows, they're getting shorter, and if it was done, of course, by an attending, could be shorter even. I mean, the big problem we had, this is a arterial trauma done intentionally, because at that time we were puncturing arteries. This is very unfortunate because we didn't want to puncture the artery. We did it, and the patient had compromise. Conclusion, I think it's already a very serious alternative to surgery. I think there's little improvements that can be brought to the device and the technique. I hope other investigators will start using it, and then as quickly as possible we should be doing what is reasonable to do, which means randomizedly comparing to surgery to show it's non-inferior. This is how we select these techniques to remain. And my take-home message for you is that you should keep away from the arteries. And myself now, of course, I'm doing it under ultrasound, which is, I think, the only way to be sure we're not touching those arteries, because those arteries are very fragile. I know Neil still does his interventions through the artery, and I think this could be a very good debate next year. Thank you.
Thanks, Joaquin. Let's move forward to the next talk. It's going to be delivered by Henry Justino, and on recognition and management of portosystemic shunts in congenital heart disease. Welcome, Henry.
Thank you very much for the opportunity to present on this topic. We're going to go a little bit outside the heart in this case today, but this has implications for our patients. So these are my disclosures. None are relevant to this topic. I'd like to review the vascular anatomy of the liver, since we don't usually think about it very often, talk about the anatomy and physiology of portosystemic shunts, discuss some diagnostic and interventional techniques, and then discuss the specific altered physiology of portosystemic shunts in single ventricle patients. So quickly, the portal circulation drains all of the abdominal viscera except for the kidneys. The splenic vein joins the superior mesenteric vein to form the main portal vein, which then branches into the liver to be processed by the liver and then comes out as the hepatic veins into the right atrium. A portosystemic shunt is a communication between any of those splanchnic veins and the systemic veins, and portosystemic shunts can be either congenital or acquired. Acquired portosystemic shunts occur because of portal hypertension. These are the typical ones we are familiar with. Collateral veins, which form varices, occur wherever branches of the splanchnic veins are in close proximity to the branches of the systemic veins, and they serve to decompress the splanchnic venous bed. So the common areas are the lower third of the esophagus and upper stomach, paraumbilical areas, retroperitoneal, and pararectal. This is the last I will speak on acquired portosystemic shunts, because we really want to focus on the congenital ones. Congenital shunts are known as Abernethy malformation, and these are large congenital venous communications between the splanchnic venous bed and the systemic veins. And these are not associated with portal hypertension. These patients couldn't have portal hypertension if they wanted to, because these are large unrestricted communications that equalize pressures between the portal side and the systemic side. There are three basic categories divided into two broader categories. Type 1 shunts are direct communications of either the splenic vein or superior mesenteric individually to the IVC, or of the main portal vein directly to the IVC. These are both type 1 shunts, and they are also known as congenital absence of the portal vein, which is a terrible term. It really means congenital absence of the intrahepatic branches of the portal veins. These people have no intrahepatic portal veins. A type 2 shunt is the type that we may get called upon to deal with, and these are the types that do have intrahepatic portal branches. They may be hypoplastic, but they are present, and there is some sort of side-to-side communication between the portal system and the systemic vein here. So the portal blood, which contains substances that require clearance through the liver, and when there is portosystemic shunting, a variety of metabolic derangements can occur. Galactosemia is actually one means by which patients can present because they can fail their newborn screen, and it can be an alternate to the true metabolic defect of galactosemia. Hyperammonemia can develop, liver hypoperfusion, which can develop into synthetic dysfunction and hypoproteinemia. They develop liver regenerative nodules commonly, and microvascular pulmonary VMs, which mimic hepatopulmonary syndrome, can also develop in these patients. So let me give you some cases from our lab. So this is a patient I treated, a 14-year-old boy, an ex-premature baby who severe bronchopulmonary dysplasia, had some developmental delay, severe hyperammonemia, was now presenting with ascites and peripheral edema, and he was known to have a patent ductus venosus, but it was thought to be too large to close. So I took him to the cath lab, and this is the characteristic anatomy of a ductus venosus. And I will put up the labels here. So this is the main portal vein that comes in, and you can see the majority of the blood takes the ductus venosus and goes through where it joins the left hepatic vein and then comes into the right atrium, and a minority of the blood goes into the intrahepatic portal branches here in the right portal vein. So we performed balloon sizing and balloon occlusion at the same time of this communication. The patient had an alternate portosystemic shunt which allowed for a veno-venous loop between the IJ and the femoral vein, and we measured that the transhepatic gradient, which is the portal pressure gradient to the hepatic vein or right atrial pressure, was only 6, which is acceptable. And so I went ahead and put a 14-millimeter device, make sure that the left hepatic vein is not going to become obstructed with a selective injection there. And at follow-up, the ammonia normalized within 2 weeks, the albumin normalized within about 8 weeks, the ascites disappeared. He had improved cognition when his hyperammonemia resolved. His portal veins grew by ultrasound, and several years later, when I recapped them, he had a gradient of only 1 between the portal system and the systemic veins. Here's another example of an intrahepatic portosystemic shunt, which is not a ductus venosus in this case. A 7-year-old boy, this was very recent, who presented to our hospital, Down syndrome, previous AV canal repair, history of seizures, and presented with status epilepticus. And despite treating his seizures, he remained comatose for several days and couldn't wake him up, so a metabolic workup was done and revealed a critically elevated ammonia level. And so imaging was performed that showed a portosystemic shunt into the IVC, but no intrahepatic portal branches could be seen. So he was thought to have a type 1 shunt, which is not amenable to treatment and normally requires liver transplantation. I took him to the cath lab. This looks deceptively like a ductus venosus, but it's not. It ends in the IVC, not in the left hepatic vein. And you don't see any intrahepatic portal branches until you do balloon occlusion. And with balloon occlusion, now you start to see the appearance of intrahepatic portal branches. So he's actually a type 2 with very hypoplastic intrahepatic portal branches. And with balloon occlusion, the transhepatic gradient goes up to 16 millimeters of mercury, with the absolute pressure in the portal system being in the mid-20s, which is much too high. He'll develop severe GI bleeding, acute portal hypertension, so we cannot occlude this type of shunt immediately. We have to provide some sort of gradual occlusion. So this is the anatomy here, main portal vein and the right portal venous branches. So what I did is I took a muscular VSD device and removed the fabric from it in order to allow very gradual accommodation and occlusion. And it's too soon to tell. This was only a very recent procedure, but on the left you can see the positioning here with the IVC, and on the right is a superior mesenteric artery angiogram with the venous phase under digital subtraction, showing that the device is still porous and not obstructing the main portal vein. Here's a case 3, a portosystemic shunt, and this is relevant to our congenital heart disease patients that can present as an occult cause of cyanosis. So a male with heterotaxy, dextrocardia, unbalanced AV canal with infradiaphragmatic TAPVR. He had a lateral tunnel fenestrated Fontan, kind of late at 6 years, and at 9 years of age, he was referred for a fenestration closure. His saturation was 87%. His fenestration was a pinhole by echo, so I could not believe that that would have been the cause of the problem. So an MRI was performed. This is a posterior view of the heart, so left on the left side of the screen and right on the right, and you can see that the confluence of the hepatic veins are still connected to the infradiaphragmatic vertical vein. And when the surgeons do not ligate that vein, there is the opportunity in patients with single ventricles who go on to Fontan for that shunt to reverse itself and for the portal venous blood to drain into the left atrium. So this physiology is very peculiar. We've seen several with this now, and it's both a portosystemic shunt and a cause of occult cyanosis that you would never be able to see by injecting the SVC or IVC. You would walk out of the lab and said, we couldn't find any collaterals because it's at the portal system, and you would have to selectively go in there. So this is a residual vertical vein, and it does present with hyperammonemia as well as cyanosis. So the options for treating this, we could try to cross the fenestration into the LA, go down the vertical vein, or we can go directly through the liver. I chose to go directly through the liver, but I want to emphasize that this is not a standard transhepatic puncture. We're not entering the hepatic vein. This is going through and through the liver, and the vertical vein is an extrahepatic structure way behind the liver. So we're actually crossing the liver entirely to go behind it. So it's not a standard transhepatic puncture. This is the left hepatic vein. On the right side, this is a technique which is hepatic vein wedge angiography, which allows you to make a small filling of the hepatic parenchyma, which then drains this way, and then you see this S-shaped vertical vein that drains into the left atrium. Now we can aim for this structure. And here it is with a catheter, with a needle entering directly into this vein, and then we go ahead and pass a long sheath over a wire, and here is the vein with a nice area of constriction prior to entering the left atrium, and we do a test occlusion to determine that it's safe to do this, and then we go ahead and place a 12-millimeter vascular plug. The patient did very well. His ammonia normalized and his saturation increased to 93%. He did still have a small fenestration and a small baffle leak, which I left alone to make sure that the portal pressure could accommodate. This is an extrahepatic portosystemic shunt, which you will encounter this if you look for it, but you need to look for it. Extrahepatic and other shunts that occur in heterotaxy need to be looked at carefully. This is a female with heterotaxy of left isomerism type, which is much more common for this to occur in, and she had a Norwood operation and then presented for her pre-Glenn, or in this case pre-Kawashima operation, because she has an interrupted IVC. And I took the picture, and I would recommend that everyone take pictures at the iliac venous bifurcation in these patients with left isomerism. It'll be the only way you'll find this. And here is pre-Kawashima, the right common iliac vein with nothing peculiar about it. It ascends on the right, crosses over, ascends on the left, crosses over to the right. But when she had her Kawashima operation, a couple of years later, she was very cyanotic, saturation of 64%. And lo and behold, no surprise, she has pulmonary AVMs in the right lung, not an uncommon cause of cyanosis in this population. But if we had left it at that, we would not have discovered the other problem. So we go down below and take a picture in the same right common iliac vein, and lo and behold, there's an enormous structure that is actually entering the inferior mesenteric vein and fills entirely the portal venous bed. So this is an extrahepatic portosystemic shunt, but it's actually a systemic two-portal shunt. It's shunting into the portal system as opposed to out of it. And that is the peculiar physiology of these types of shunts in single ventricle patients when you elevate the systemic venous pressure above atrial pressure by doing a Kawashima operation. You can actually get a catheter all the way through, take selective pictures in the portal system, and then place a vascular plug. You do not need to test occlude these because the shunt is actually going into the portal system. Clearly, it's not a matter of hypoplasia of the portal veins or inability to accommodate the flow. You're actually removing flow from the portal system. And this is the final case with a very complex portosystemic shunt, again in left isomerism. This is a patient with interrupted IVC again, had a BT shunt initially, and then had a pulsatile Kawashima operation, and then presented to us for a cath because she had a saturation of 80%. And again, I want to show out a very important point. On the left panel, pulmonary AVMs, but always look for this, and this is very, very abnormal, and you should always look for this. If you ever see the azygous vein flowing down, that should never happen in a Kawashima. That has to always go into the lungs. So if you see contrast heading down the azygous vein, go look for something, and you should have a very high index of suspicion that it will be a portosystemic shunt. And indeed, we take a picture by the iliac venous bifurcation, and you see an extremely complex splenorenal shunt that with reverse flow in the renal vein, it's going into the kidney, coming out through a portosystemic shunt, coming up the main portal vein, and into the portal circulation. So in this case, it is a selective injection. Thank you. Here's my colleague and I from radiology put a catheter directly transportally. Again, this is not a transhepatic, it's a transportal procedure. Put a sheath in there and put a device to occlude it, and then put several more coils to occlude. And finally, on the right panel, you will see that the right renal vein finally flows in the correct direction, which is out of the kidney as opposed into the kidney. And two final angios, again, retrograde flow down the azygos. You should prompt search for something, and here's another very complex splenorenal shunt in left isomerism, and this final one as well with descending flow down the azygos vein with an exceedingly complex left splenorenal shunt which comes through and comes up into the portal phase very late. So, in conclusion, portosystemic shunts are complex venous anomalies with myriad presentations. They can coexist with congenital heart disease. They can lead to metabolic derangements, and in patients with single ventricles and infradiaphragmatic vertical veins, these may be a cause of portosystemic shunting and cyanosis, and in patients with left isomerism with polysplenia, these are very bizarre physiologies with alternating systemic to portal and then portal to systemic shunting that can occur, and our community of pediatric cardiologists really should become more familiar with this type of anatomy so we can help manage these patients. Thank you so much.
All right, our next talk will be covered stents congenital heart disease by Elchanan Bruckheimer, and I'm going to ask the presenters please to adhere to the time. We're very short on time here right now. Even faster than the time allocated.
Right, so the question was, are BMS outside of the US becoming obsolete? And the answer is no.
Expand.
I trained with Bill, so. Okay, so anyway, so I'm a consultant for Atrium. So I think when you're going to talk about are BMS stents obsolete or not, we should spend a couple of seconds just what type of stents are there. So the closed cells and their open cells, there's covered stents, there's self-expanding, there's biodegradable, and there's all different types of making them where they can be laser cut, welded, or braided. And the materials that are around are stainless steel, chromium, cobalt, platinum, iridium, nitinol, biodegradable, and EPTFE covers. All of these are going to influence the type of stent that you're going to choose. The material and the type influence the strength and the flexibility of the stent. A closed cell will be strong but stiff and shortens, whereas an open cell will be flexible, can adapt, but is weaker but less foreshortened. Chromium cobalt is stronger than stainless steel and gives you thinner struts, which gives you a smaller profile. So if you compare the Andra stent, which is chromium cobalt hybrid and open-closed design, which is open and closed cell design, to a Palmaz XL14 series, which is stainless steel closed design. So if you're thinking about doing RVOT, maybe you want the Andra stent. If you want a very stiff stent, but you don't worry about foreshortening, use the Palmaz. So strength and expandable size and delivery system influence the size of the delivery sheath, so it depends on the size of the patient. And what balloon do you need to use? Do you use a high-pressure balloon, a low-pressure balloon? Are you going to post-dilate? And does your stent come pre-mounted? So I think making is something obsolete or not obsolete. It's just that we have a bigger armamentarium, and we have to decide what we're going to do. So we need to know our stents better. So what am I treating? So I think the answer is you can't get to know all the stents, but you need to get to know a few stents well. And you need to determine the requirements for the specific problem. So if you have a patient here that has severe RV failure with bilateral PA stenosis in an infant, or if you're doing an RVOT, a native RVOT for PPVI, or whether the patient has an aneurysm in SVPS, status post balloons. So if you look at this patient, this is a small patient, it's a small delivery system, you want to implant two, you need to put one next to the other, you do your measurements, putting in two large stents in this patient would be difficult, using the pre-mounted Genesis stents would be much easier, and you get a good result, and these stents can be post-dilated up to 14 millimeters, so I would use a bare metal stent in this situation. For the native RVOT for PPVI, there's no conduit in there. You're not going to get calcium that's going to, and you have a nice little narrowing here. I'll do the APs and the laterals. So using an Andra stent in here will give you a rough and ready approach. We discussed that yesterday during the live cases. And then you can pop in your Melody or your Edwards, whatever you prefer. And again, if you have an aneurysm and you just want to get rid of the aneurysm and not have all this flowing out, so you can put in a couple of stents and put in a covered stent, and that will close your aneurysm, hopefully. Anyway, there was a registry done which looked at balloon angioplasty, stenting, and the adverse events. It was by Ralph Holzer, and this came out in 2011. And if you look what type of procedures were done for pulmonary arteries, so a lot of them had balloon angioplasty. Of about 500 stents, There was about, most of them, or half of them for the peripherals were pre-mounted, a lot of them were non-pre-mounted. Covered stents was something which is not really used in the pulmonary arteries. So are bare metal stents obsolete? No. If you're doing pulmonary arteries where there's branches and so on, and it's different anatomy than the aorta, you probably still use most of the time bare metal stents, unless you're doing conduits, which are calcified, as we discussed yesterday. However, it's a different situation when you get to coarctations. So this is a coarctation on a 2-year-old patient done outside my institution. She was 2 years old. They did a native balloon angioplasty. We don't do balloon angioplasties. This is the reason why. She had a little tear at the back. And 5 years later, she had a nice little aneurysm there and a mild recoarctation. I like using 3D rotation angiography. We've seen examples. It's becoming more popular to be used. I think it gives an awesome amount of information, especially in this lesion. So we did that with a covered stent, Vanta V12LD, and you can see how nicely you can see that as well, using 3D rotational. Now, obviously, we use bare stents in the coarctation of the aorta. They're better than angioplasty. They support the aortic wall. They're effective when you have discrete, tubular, and long coarctations. The side branches remain patent, but you need to further dilate them, obviously, and you can also get aneurysms and dissections with them. So here, this is a nice result. We can see the subclavian has stayed open, and that's a nice result. Why do aneurysms occur? Well, it's multifactorial. Flow disturbances, cystic medial necrosis, depending on the age of the patient, obviously calcification, previous suture lines, and intimal disruption because someone's put a balloon or a stent there beforehand. Why would you use a covered as opposed to a bare stent? Well, because it reduces the extent of the intimal tear. It creates a longitudinal framework. Well, that's true of a bare stent, but a covered stent would give you more integrity over the vessel wall, at the coarc, and below it where there's post-stenotic dilatation. And it's particularly useful when aneurysm is present or there's a risk. So, the CCISC published 2 papers, an acute and an intermediate follow-up. The significant complications were 14.3% in the acute. The efficacy was high. There was technical complications, but aortic wall complications occurred in 3.9%, aneurysm, dissection, or tear. In the intermediate follow-up, the follow-up imaging was only available on 578 patients, 25%. 12.5% of those patients followed had aneurysm, dissection, or tear. In another paper, which is Chakrabarty's paper, they had 88 patients with coarctation. They had 102 stent procedures over a period of 6-7 years. There were 4 acute complications. 2 were related to the aorta. But a follow-up CT was performed on almost all these patients, and only one of them developed an aneurysm associated with the redilation of a stent. Now, if you compare those 2 papers, which came out around similar times, 2 years after the other one, the similar percentages of native coarctations use the same definition for aneurysm formation. Why was there a difference in the rates of aneurysm formation? One of the reasons is because there was a small percentage of the CCISC cohort that went follow-up. So you may only be following up imaging those patients that were at more risk or needed more interventions, therefore you've found more aneurysms. But the other thing to notice is that in the CCISC group, only 2.7 of the stents implanted were covered, whereas in Chakrabarty's report, 28% of the stents were covered. Would you balloon this? Would you put in a covered stent, or would you put in a bare stent? I would put in a covered stent. I don't know which one is the better one. I represent this one in most of my talks. I use a lot of these as well. This is a coarctation in that patient. And I think that one of the comments made yesterday by Z and followed up by Eric, that there's been some infolding, is that I looked at my cases, and I tend to oppose the stent to the posterior wall as much as I can here to prevent a cul-de-sac which could impinge on this covered stent. Because the difference between the Advanta and the coarc and the CP stent is that the CP stent, the Gore-Tex doesn't cover fully. So if you have a little bit sticking out and having a cul-de-sac, flow can still go through the top 3 millimeters of the stent until it hits the Gore-Tex. That may make a difference, I don't know. I think rotational angiography is very important in coarctations. This is a standard lateral. This is a rotation of the same patient. And here you can see there's a coarc and a cauliflower aneurysm. So I don't think these are eye candy. I think there's a lot of information. Here again, because we want to get the aneurysm closed, we will squash down the stent this way. I don't know why this is not working. And we bend it back to the subclavian. We have very good apposition. And you can see by spinning it around that you can deal with the coarc, you don't close the side branches, and you get a good apposition. The reason why we think apposition is important, this is a native coarc in a 16-year-old. I put it in with a 16 balloon, and here you can see that I'm not well opposed. I'm not sure you would have seen that if you had not done rotational angiography. So we did it again with an 18 balloon, and you can see how nicely it's opposed. I don't think covered stents need for the weird and wonderful. Obviously, this is very useful in this patient that had a very weird type of co-arc. We've now enrolled all the patients in the co-arc study for the Advanta V12. We have the primary endpoint follow-up is now on 64 patients, I think. We have a few patients, so hopefully at CSI or next PICS we'll be able to present the full follow-up data and then make a true discussion of all the complications and so on that exist. I don't think bare stents are obsolete. I think you really know what the patient and the lesion require and which stent properties are available, and that will govern the correct choice of stent. I think covered stents in coarctation are probably safer for dealing with later complications such as aneurysms. However, intermediate and long-term results in all patients need to be evaluated, and we probably then need to compare the covered stents. Thank you very much.
Spectacular.
One more slide. One more slide. There you go.
Terribly sorry we don't have time for questions. The talks in this session have been spectacular. Tom, welcome. Welcome back from your sterling work doing the live cases. Tell us about right ventricular outflow tract conduit rupture and how you're going to spot it and prevent it.
Well, thank you. Again, thanks for all of your wonderful participation. We're very excited about how this meeting has gone and look forward to seeing you in Chicago next year. The talk I'm going to give here on conduit rupture and the specific title of pre-procedural risk identifiers is perhaps going to be more of a promise than something I can deliver on, but I'll do my best. These are my disclosures. So in the course of my talk here, I'd like to define conduit rupture. Let's try to delve into that a little further. I'd like to spend a little time also discussing the physical properties of RVOT conduits and what these dilating forces are and how they act on these structures. And then let's look also at the incidence of conduit ruptures, at least as much of the data we have to take a look at. And then, of course, in much time as we have, we'll try to discuss some of these potential risk factors and consider some strategies to deal with it. Essentially, conduit ruptures can be considered, I think, basically in two flavors. One is a contained or a tear that does not lead to contrast extravasation or bleeding beyond the mediastinal scar tissue surrounding the conduit. I think you can expect that a tear means that you have gone through the entire conduit, and what's holding it in place is whatever perivascular scar tissue is present as a result of the healing response. Non-contained or uncontained tears, of course, are those that lead to free communication. You can see in the upper angiogram the tear here in this heavily calcified conduit after initial dilation does not extend beyond the outer boundary of the conduit. And in the lower panel, you can see that in a patient that's already been pre-stented, had a melody valve put in and a post-dilation, that the contrast is actually exiting the mediastinum and coursing into the left hemithorax. This patient bled 1,250 mLs in 4 minutes into his left chest before a covered stent was placed and eliminated the problem. I think it's safe to say that it's pretty unsatisfying to define conduit ruptures as having already happened, and what is then left is it going to extend or is it going to lead to catastrophic bleeding? It's also true that these contained tears have an uncertain potential to progress, either chronically or even in the course of further dilation of the conduit in preparation for placement of a transcatheter pulmonary valve. We need to consider how to cover these contained tears, whether they should be covered and how to do it. And of course, it's clear from our prior conversations over the past few days that there are some significant limitations, at least in the United States, that unfortunately create a reactive rather than a preventative approach to conduit rupture. So right ventricular outflow tract conduits, as we know, undergo a process of aging and degeneration that leads to decreasing compliance over time. They become less stretchable. That means that the tensile strength, that's the force that's required to actually break or tear the conduit, decreases over time. It's also true that this time course is quite variable, and it's very difficult to predict in advance over what period of time these compliance changes are going to occur. It's also true that the suture line itself behaves differently. So the suture line is a boundary where there is essentially a ring of scar tissue, a very monotonous layer of fibrous tissue between the lumen and the outside of the conduit. And some of the most prominent disruptions that we saw in the U.S. clinical study were at the suture lines. And the dilating forces, of course, are going to concentrate most in the compliant regions of the conduit. If you think about this, if you look at Laplace's law, what it tells us is that the larger the vessel radius, the larger the wall tension required to withstand a given internal pressure. There's the pointer. The equation is that the wall tension is equal to the pressure in the vessel times the radius. So at larger radiuses, larger wall tensions are generated for a given pressure. So a 10 millimeter dilating balloon is going to create half the wall tension that a 20 millimeter dilating balloon will create. Yet the conduit may behave very similarly. The tensile strength of a 10 millimeter conduit and a 20 millimeter conduit may very well be the same. We don't know that information, but it seems to make sense, at least on first principles. So larger increases in wall tension are associated with a sudden increase in this radial force, and this is what we see when these balloons tend to jump. Looking further, if we go to the large series that was published by Lin Ping in 2006 from the Boston Children's Experience, in which RV outflow tract stenting was performed in 242 patients, there were 6 patients in that cohort that experienced a contained rupture. That's a 2.5% incidence. One of those patients received a covered stent. None of the rest did. It was described in the study that fluoroscopically visible fractures of the calcified conduits were common. We don't know what common means in terms of percentage, but that was the term used in the paper. If you look closely at this data, though, it turns out that only 14% of this cohort had conduits that were 20 millimeters or greater. So the wall tension exerted on the average conduit in this study was significantly less than the type of conduits that we're treating when we put percutaneous valves in. If we look a little further at the U.S. Melody clinical experience, both at the pivotal study and the post-approval studies, we now have a total of 247 patients that are enrolled and being followed in that trial. Of that cohort, 9 patients had a major conduit rupture as defined by the investigator that required emergent treatment. That's a 4% incidence of concerning conduit rupture that was subsequently treated. 8 of those 9 patients received a covered CP stent emergently, and 1 required emergent surgical treatment. Looking a little further, if we look at the NUMED registry of the U.S. use of covered CP stents when placed in the right ventricular outflow tract, we have now a total of 50 implants performed from 2009 during the pivotal study up to July of last year. 31 of those were emergency use and 20 were compassionate use patients. In the year 2011, there were 23 of these CP stents placed, covered CP stents, and 650 melody valve implants, yielding a incidence of 3.5%. At the same time, we've also appreciated there's a significant value in pre-stenting these melody conduits to mitigate the stent fracture risk, and that's led to a much more aggressive policy towards dilation and pre-stenting. We also know that there are a significant number, we don't know the numbers, but there are patients that we are aware of that have had homemade stents used. We saw one of those used yesterday in the live case that I attended, and have patients that have undergone emergent surgery. There is one patient that Medtronic is aware of who had a total of 5 melody valves implanted in the single procedure to manage a tear that kept us extending beyond the existing melody implant. And then we also know of at least one patient in the United States who's died as a result of a conduit rupture in a lab that did not have access to covered stents. So what are the risk factors? We know that in the U.S. clinical data that all of the conduits were homografts, although only 70% of those of all patients treated with the melody valve in these studies had homografts. Now, I'm not going to say more about that, but it does seem that homografts might be a potential risk factor. Stenosis, yes. 8 of the 9 ruptures occurred in stenotic conduits. Heavily calcified conduits, we don't really have enough information to say. A number of these ruptures occurred in patients with minimal or no calcification. But that's speculation on my part to say that there's certainly, I think, a bias towards heavily calcified conduits as being at risk. The balloon stenosis ratio, however, may yield some information here. In the Medtronic cohort, the average was 150%, all the way up to 240%, and in the NewMed experience, 190%. That's the initial dilating diameter used to test the compliance of the conduit. The Melody instructions for use suggest that you don't exceed 110% of the original conduit size, but that's the final implant goal. It was never intended that that was the guidance for the initial compliance balloon testing. So what are your options? You can stop the procedure, of course, if you see a contained tear. If you have an uncontained tear, you better keep doing something. But if you have a tear that you are concerned about, one option is to stop. The other option is to use the Melody valve as a covered stent, but then you lose the opportunity to pre-stent that conduit and mitigate the stent fracture risk. A balloon expandable covered stent, such as the CP stent, is an option in much of the world, but in many labs in the U.S. is still not available. Other options, including self-expanding stents, have been described. And then you always can consider surgery as an option, either urgently or emergently. One strategy also to suggest here, and I don't have a lot more data to say that it makes sense, is to do gradual and sequential conduit dilation and consider using your initial dilating balloons at sizes that are only going to produce a waist in the balloon of about 80%. Well, that's 125% of your stenotic diameter, not 110% of the original conduit size. Check angiography is important. Using a long sheath helps facilitate that. That can also be the sheath that's used for your bare stent deployment or covered stent deployment, and it speeds the process along and it gets that angiogram done a lot more quickly. Ultimately, our surgeons may be of help as we plan these future surgeries, considering bioprosthetic pulmonary valves when possible. Preparing includes having these kinds of covered stents available that we've discussed already. And then finally, in the United States, there is a brand new study. Rich Ringel just sent this information out. It's called PARCS, or the Pulmonary Artery Repair with Covered Stent Study. This will allow both retrospective and prospective enrollments. U.S. sites that can participate are those centers that have been approved for Melody implantation. Those are centers that have been trained, proctored, and have done at least 10 procedures. You will require IRB approval and a consent form to be used. What it does not allow is prophylactic use of the covered stent at this point. So in conclusion, 4% incidence seems to be about where we're at with the data that we have available. Uncontained tears, the immediately life-threatening ones, fortunately are less common, but we have seen can be fatal. The IFUs, remember, do not suggest that the 110% number be used for initial conduit dilation. That's a potential ultimate goal, and based solely on the fact that the retrospective experience from Boston used that value. That was an institutional standard. It has no more basis than that. And participating in PARCS is certainly a great option for those of us in the U.S., and preemptive covered stent use at this point in the United States requires compassionate use approval with your IRB and consenting and all of the paperwork involved in that. So thank you very much.
We're now going to move on to our last presentation this morning. This presentation is being transmitted back to Japan television. We are honored to have Dr. Sano give us a lecture on tissue engineering and the management of hypoplastic left heart syndrome. Thank you very much.
Good morning, the members, guests. I must say thanks to the organizing committee to invite me to this meeting. I was very surprised yesterday night that you were so active and fantastic compared to the cardiac surgeons. My topic today is tissue engineering and the management of hypoplastic left heart syndrome. The Okayama is far away from Miami. The time is 1 o'clock at night, and I try not to sleep. And then if you fly from United States to Tokyo, and you change the flight to the domestic one, and the Okayama is a 1 hour flight from Tokyo. The Yokohama is situated in the west part of Japan and near Osaka and Kyoto. It takes within 1 hour by bullet train. We have a very nice castle and one of the 3 most famous Japanese gardens named Korakuen. The Okayama University was established in 1870s. We have a nearly 900-bed general hospital. When I was a medical student, I played soccer. My dream was to become the famous, very good soccer players, but I soon realized I have not much talent, so I changed my dream to be a cardiac surgeon. My mentor is Brian Barrett Boyce, and also Roger Mee in Melbourne. So after I worked with Roger, I was back to Okayama, my home town, and then start my program. And we are doing 300 congenital with plus an ASD closure. Now, the most of the ASD is closed by caster. So that therefore, the most of our cases are complex. Here's the annual report of Japan. In 1998, the mortality of neonate open heart surgery was 33%, and in 2005, it decreased to 17%. In each, the diagnosis and transplantation of the great arteries, the mortality was 20%, and in the recent result, down to 7. What about our unit? In 5 years, and 204 neonate open heart surgery, the 40 are hypoplast, and we lost 5 patients, and 1 heterotaxy and 4 hypoplast. You know the hypoplast, the classical node, and you're very much familiar with the hybrid. I used the RVP conduit in February 1998, the first time, using a 5 millimeter Gore-Tex non-valved conduit between RV to PA. And since then, until October 2010, we have done 100 infants. Then the current status of all cases in stage 1 survival 90%, and overall survival was 73. If we think of the normal risk hypoplast, excluding the hypoplast with intact atrial septum, restrictive ASD, and premature and the babies, and the low birth weight. Then the stage 1 survival was 97%, and overall survival was nearly 90%. So now the result of all the complex heart disease improving dramatically in these 10, 20 years. However, if you look at the long-term result, even the hypoplast, even the mortality was 10% or less, then a 5 or 8 years mortality is high. And because some patients die due to heart failure, also the no option of heart transplant in Japan in these small babies. Therefore, we think of the regenerative medicine, so tissue engineering to these patients. The cardiac regeneration therapy to severe congestive heart failure, we are started using the right atrial wall to the hypoplast patient. As you know, that initially these regenerative therapy started using peripheral blood and skeletal muscle, etc., etc. Now we know that the cardiac progenitors in the cardiac muscles itself. I think there's almost 10 years or more to use this technique. However, there's almost no successful report. In 2011, there is one paper to the Lancet, and they used cardiac stem cells in patients with ischemic cardiomyopathy, and they showed improving left ventricular systolic function and also reducing infarct size. Also another the paper in the Lancet reduced scar muscle and increased viable heart mass. That's the two major now the report to the cardiac stem cells. So it's not fascinating to the clinical aspect. We know that the neonatal infant are different from older children and adults. The response is so different. If you look at this case, pulmonary atresia intact ventricular septum with a very, very hypoplastic right ventricle with RV2 coronary sinus communications. Well, if we do pulmonary valvotomy in a shunt in a neonatal period, these hypoplastic RV grows. This is another example of the pulmonary atresia intact ventricular septum, the same, the hypoplastic RV with coronary sinusoidal communication. This patient also responds to the pulmonary valvotomy. So even if we do the same procedure to older children, it doesn't respond. So we know the neonatal infants are completely different. If you look at the cardiac progenitors, a child has much more progenitor compared to adult, and this is in RV outflow tract, and then on the right atrium, and the LV is the smallest number. And all the people are doing research in this age group with infarct myocardium. We changed our project a little bit different. We use this age group with a hypoplast and child, and using right atrium. So we did the phase 1 trial from 2011 to last year already finished. The Japanese government requested us to do 7 cases. So we chose the hypoplastic left heart syndrome, and when they do Gren or Fontan procedure, we took out the small piece of right atrial appendage and cultured, and 1 month later we delivered through the catheter, and 3 months and 1 year later we did they analyzed all the patients. This is the small sample, and then through the catheter they inject through the coronaries. This is the list of all the 7 patients. The 3 are at the Gren, and 4 are at the Fontan. This is the catheter to inject to each coronaries. The cardiac function analyzed in an echo. This is just the usual hypoplast before we do the started stem cells, the before shunt or the 12 months after the shunt, the ejection fraction is not much difference, and by angio also the same, not much difference. This is the patient with stem cell therapies. The ejection fraction improved, especially this patient. The low ejection fraction improved 22%. By echo, the same, and the angiogram also the same, improving. And the stroke volume also improved, and especially the wall mass increased 3 months after that the stem cell transplant. Series analysis of cardiac function after reconstruction of the hypoplast, the before in usual series, it's all not much difference. But then we finished at analyzed 2 patients 1 month after the transplant. These 2 patients, especially this one, low cardiac function before, and then improved 3 months later, and then 6 months, 12 months, as still improving. And in MRI, also the same, improved. This is just one case. It was the baby with the hypoplast and bilateral PA banding at the other institution, and then the ejection fraction got worse, so the patient will refer to us. Then we did a node sun operation, and then bilateral Gwen. And then at that time we sampled from right atrium, and then 1 month later the cell infusion from the coronaries, and then 3 months time regular evaluation. This is the angiogram. Here it is 3 months after cell infusion. It's also the angiogram and the lateral view, and the before and the after. This is the MRI, also the before and 3 months after cell infusion. This is also the MRI lateral view, and 3 months after. And then in the echo, this is before and after cell infusion. So these are our team with the principal investigators, Professor O, and also our pediatric cardiologist and intensivist and interventionist, Professor Otsuki, and my postgraduate surgical fellow, Tarui. This one was the broadcasted from the NHK, the World News.
Doctors in Japan are using a groundbreaking therapy to treat children born with heart problems. Regenerative medicine uses the patient's own heart cells to improve cardiac function. If this new technique fulfills its potential, doctors could save lives without resorting to heart transplants. NHK World's Masami Hori has the story.
Hypoplastic left heart syndrome is a serious condition that affects 1 in 10,000 people. This 3-year-old girl was diagnosed right after she was born. The left ventricle of her heart was not functioning. Left untreated, this condition is usually fatal.
Right, next one.
As an alternative approach, Okayama University Hospital began conducting research into regenerative therapy last year. First, some tissue is taken from the patient's heart. These are the extracted cells, and this is what they look like after being cultured for 10 days. The bits that look like fibers are the cells that have multiplied. The cells are then put back into the patient's heart.
Regenerative medicine makes sense because you are using the person's own cells, so there's no need for medication to prevent rejection.
The 3-year-old girl underwent this treatment in February. After culturing and multiplying heart cells and then replacing them, the doctors are hoping this will boost her cardiac muscle and allow her heart to pump more strongly. 3 months after the procedure, the child was brought back to be examined.
心筋のその大きさですよね、重量っていうのは少し厚みが増えて
There was a 5% increase in the heart's ability to pump blood. This means the child's restrictions on liquid intake may be removed soon. This is the 7th case treated with regenerative therapy at the hospital. The other 6 children have made similar progress.
We think that regenerative medicine could be used to treat most people who are in need of heart transplants.
And Masami Hori, who filed this story now. And Masami Hori, who filed this.
So we finished the phase 1, and the government approved our new approach, and then we start the phase 2 from next week. We expand this technique not only to hypoplast but also the synchro ventricle patient. They request us to do 34 randomized study. If it's approved, then we need to do multi-center study. I think some of the unity in the United States are very much interested in this new project, and I hope we can use this technique and then to save these heart failure babies in very soon. Thank you very much for your attention.
We want to thank you very much for this look into some new and therapy and innovative therapy that could help all of us. Dr. Sano, can you just wait 1 second? We have a few minutes for questions. This is going to go into the break a little bit. If those want to go into the break, get coffee, because we will start the live cases at 11:50. But if there are any questions, let's please have some questions down. Yeah?
Professor Sano, this is really very commendable work, and delighted that growing children are getting the chance of this sort of regenerative therapy as opposed to the adults who've got horrible myocardial ischemic hearts. But I just want, there are many groups now, including in Japan and in the UK, who are going beyond stem cells and actually producing cardiomyocytes. Why not infuse cardiomyocytes rather than the stem cell itself? Could there be some disadvantage of using cardiomyocytes other than they're a little more difficult to culture? Is there a reason for that?
I don't know much about this because I'm only simply the pediatric cardiac surgeon. But the researcher, the Dr. Orr, I used to work in Kyoto University and use the stem cells and myocardial site and also the iPS. Oh, he knows all about this technique, and then he finally used this stem cell, cardiac stem cell, to use the adult. But unfortunately, the result was not as good as they are expecting. So he came to talk to me, and then I talked to him. The neonate and the small infant a completely different response. So that's the only simple reason why we started this technique.
Thank you. Bill, this.
We have two questions, one over here.
And I'm just wondering how much tissue you need. I'm just thinking of cases of myocarditis and whether that tissue can be obtained by biopsy specimens for this subset of population.
When we do the cardiopulmonary bypass, we put a purse string to the right atrial appendage. So we take just a small piece of right atrial appendage, very, very small. Otherwise, we just take it out. So within 2 or 3 weeks, they cultured, and maybe very easy to increase 100, 200 times more.
Timur?
Jean-Gislan, thank you very much for the nice talk. Our hypothesis is, in relating to the question of Neil, that not the myocytes are the problem, but the ischemic or the vessels, the angiogenesis maybe, is the problem and the target. So our hypothesis, and we treated even some compassionate patients with a dilative cardiomyopathy as well as one with a hypoplastic left heart, and our hypothesis is that this is a, let me say, a vessel disease, maybe a Kawasaki disease of the endocardial vessels, and that secondary we have a myocardial problem. So my question is, do you try to differentiate between a, let me say, ischemic hypoplastic right ventricle in opposite to maybe a non-ischemic one? Do we have any strategy to find out, is it as a ischemic failing right ventricle or is it another type of failing ventricle? Because our hypothesis is the stem cell treatment currently is an improvement of vessels. You can stimulate the angiogenesis, not so you can stimulate the myocyte augmentation.
It's a very good question, and I also wondered whether these stem cells and stay in and it grows in the myocardium or not. Before we did the research of the angiogenesis project. So I talked to them that whether these stem cells stayed in the myocardium or not. We started like a clinical trial first, and then we found it works. We don't know whether, even I don't know whether it's fixed, stay and grows, or just only angiogenesis or chronic like inflammations. So the next our research is to like the labeling each cells and chase it, whether it stay in the myocardium or the myocardium will change because of the angiogenesis or other factors. So that's our next research. And also we do not know whether it works to the ischemic myocardium or not. That's next to our project.
I will come to Japan later.
Yes, well.
All right, thank you. Thank you very, very much, Dr. Sano, once again.